Hello, everyone. Good evening, and welcome to the July webinar presented by the National Keratoconus Foundation, which is a program of the University of California, Irvine. My name is Jason Marsak, and I'll serve as your moderator this evening. Also with us tonight, Taylor Young from the National Keratoconus Foundation will be curating questions from the audience. So during tonight's program, if you have a question based on what you hear, you can type it into the question or chat box on the right part of your screen. We will have some time during and at the end of the presentation to answer a few audience questions. Tonight's topic is focused on the patient experience with corneal crosslinking. And we are very fortunate to have Dr. James Loden with us today to share his experience. Dr. Loden completed his ophthalmology residency at the University of Tennessee prior to moving to Indianapolis, where he underwent extensive fellowship training in corneal transplants, refractive surgery, and anterior segment reconstructive surgery. He is currently a clinical assistant professor at the University of Tennessee College of Medicine, Department of Ophthalmology. A board-certified ophthalmologist and a fellowship-trained LASIK and cataract specialist, Dr. Loden is also a member of the American Academy of Ophthalmology and the American Society of Cataract and Refractive Surgeons. Lastly, Dr. Loden is a member of the Society for Excellence in Eye Care and certified by the American College of Eye Surgeons. Dr. Loden has been in practice for 24 years, so he brings both a wealth of experience clinically, academically, and today related to his experience as a patient with corneal crosslinking. So without further ado, welcome Dr. Loden.
Thank you so much, Jason, and thank you everybody for tuning in tonight. I probably have the dubious distinction of maybe being the only ophthalmologist in the United States that has actually ever had cross-linking performed. At least I'm the only one I've ever heard of. And what I want to do tonight is just talk about that experience. We don't want to go totally into the science of cross-linking and keratoconus. We're going to give a little brief discussion on that starting out because we may have viewers that haven't been on some of the prior webinars, but you've had some great speakers, Bill Trattler and other friends of mine, going over the science of cross-linking and how it works, how it's performed. I really want to go over more the experience, what it's like from a patient perspective to go through it, why I made the decision to go ahead and have my right eye cross-linked but not my left eye, what techniques did I choose, why did I choose them, things that may help you with your decisions through the process of this. So, a little bit about my history. Had keratoconus, obviously, participated in the US FDA clinical trials with the VIDRO system. That's the only system for cross-linking currently FDA approved in the United States. And we're using a non-FDA approved device now. We'll talk a little bit about that potentially. What is keratoconus? Keratoconus really is the fibrils of the cornea are just too loose. They're frayed. They're like little ropes pulling across each other. A lot of people think it's thinning of the cornea. Thinning comes later. For example, my corneas are nice and thick. I actually have over 500 micron corneas. The average thickness is 550 microns for a cornea. Both of my eyes are right around 550 microns. So I don't have thinning. I just have irregular astigmatism from my keratoconus. But the incidence of keratoconus is somewhere around 1 in 1,500 is what the textbooks say, but a lot of people are now saying it may be much higher, even 1 in 500. So when you just look around, there's a lot of people. If you go to a professional football game and look around that stadium, there's tons of people there with keratoconus when you think about it. But these fibers, what happens is they're not tightly bound enough, and they allow the cornea to bulge, causing astigmatism. The irregularity of the astigmatism causes distortion of vision. And then as it progresses, you get the thinning, and that's when you get scarring and you start having bad outcomes with cross-linking even. You may have perforations of the cornea. You may have to have emergency cornea transplants. The whole purpose in my mind of doing cross-linking is to catch it now early enough so that you never have to go through that. Catch it when you're young, get it cross-linked early, and be able to not have to endure cornea transplants or any of the sequelae that come about from not seeking care earlier. So let's talk about ways of doing cross-linking briefly. The classic FDA-approved way is what's called epithelium off, where we take the epithelium of the cornea, scrape it off, soak the eye with a vitamin, a B vitamin called riboflavin for 30 minutes. And then we do a 30-minute light treatment at 3 milliwatts. And it's ultraviolet A light that we treat the cornea with. It causes a chemical reaction that changes the bonds in the cornea, disulfide linkages between the corneal fibrils. And this increases the strength of these collagen fibrils in the cornea. It's said to even increase it by 400 times. So dramatic increase in the rigidity and strength of the cornea. And the purpose of this is to prevent the keratoconus from progressing. You may not stop the stigmatism that's already there. You may not make it reduce. On average, it reduces about 1.5 diopters, but it's not going to be something where it cures your keratoconus. It just prevents it from progressing. And that's the classic treatment that's been around for years and the most studies performed on. We're going to discuss a little bit on Epi on crosslinking, where you leave the epithelium on. The problem, though, with leaving the epithelium on is you're not going to get as deep of a crosslink. You may not get as good of an effect. In my mind, this is a procedure I would use only for mild early diagnosis of keratoconus. I use this, a modified Epione technique in my eyes. And the reason I did is I needed a really fast visual recovery, and I was willing to risk the depth of the crosslinking, the effectiveness of the crosslinking for the speed of recovery so that I could get back into surgery. Other procedures can be done with crosslinking you'll read about that are non-FDA approved. You may smooth the cornea with an excimer laser, a procedure called PTK. I've used that very successfully on steep keratoconus eyes to take off this really the apex of the mountain, if you may. There's other surgeons doing concomitant PRK, photorefractive keratectomy, excimer laser, laser vision correction is what it is, in combination with keratoconus. I have one major concern with that, though, is there are several reports of getting serious and significant haze reactions by combining the two procedures. And that's made me very reluctant personally to have a combined procedures or to recommend it to my patients. Another issue we have with crosslinking is reimbursement. There's tremendous issues with this. In fact, we're not even able to get reimbursed by most commercial insurance payers by using the traditional Avedro system. We have tried it and we constantly get denied by carriers. It's a major issue in the United States for unknown reasons to me. So now let's just kind of go into my story and how I got diagnosed with keratoconus, what I think caused my keratoconus, and how I ended up getting treated. And in 1990, I was in my second year of medical school, and I noticed that my eyes started shifting a little bit. And it really wasn't that concerning. I just simply changed my contact lenses and changed my glasses prescription. By my fourth year of medical school, though, I became really concerned. My right eye got to the point that I really couldn't see that well with glasses. I was noticing I wasn't seeing the 20/20 line even with a pair of glasses. Went to see a local university cornea specialist at Memphis, and he diagnosed me with keratoconus. Now, remember in that time, though, we did not have the diagnostic equipment in 1990 and 1992 that we have today. We did not have corneal topography. We didn't have corneal tomography, machines like the Pentacam, the Galilei, even just simple topographers like an ISIS topographer that would have made it very, very easy to diagnose keratoconus and maybe even diagnose it earlier. We didn't have a treatment. You basically just told people not to rub their eyes and hoped it didn't progress. And there just wasn't much out there for hope. If you had a highly progressive case, you were going to end up with a cornea transplant. And that's just all there was to it. In my particular case, I really feel like my keratoconus came about from eye rubbing. I think I obviously had an eye that was predisposed to it. But in studying for medical schools, I mean, we were memorizing notebooks this thick every single day, just going through them, studying from 8 in the morning to 11 at night. And while trying to memorize, I was putting my hands on my eyes, keeping my eyelids closed, but that was putting pressure actually on my cornea. And I feel like that pressure is what caused my keratoconus. After I was diagnosed, I quit touching my eyes. I quit rubbing them at all. I would just kind of, if they itch them in the corner, but no rubbing where I've actually felt the eyeball. And I was very, very lucky and fortunate that my keratoconus did not progress. I did not want to have a cornea transplant. I knew that. The transplants can work great in keratoconus eyes, but there's still a host of complications that can occur that we won't necessarily go into tonight. But I think back now, if I could have been diagnosed in my 20s when it first started up and had a doctor recommend that I be cross-linked, I would not be wearing gas perm contacts. I have to wear gas perm contacts. They're in right now. I get great vision through them, but the comfort's not great. The vision in my right eye fluctuates. I wish it were a little crisper, sharper in my right eye. I wish it was like my left eye, which sees fantastic. I just think back to that, man, wouldn't it have been great to be able to get cross-linked? And that's the message I give to anyone thinking about it who's young, who has mild keratoconus. Man, as a cornea specialist, a guy that's been through it, I would do this in a New York second if I was a young person kind of sitting on the fence. It's a great investment. You may have to pay for it because the insurance may not cover it. But to imagine getting stability and not having to have a disease progress and get worse throughout your life, and to get a lifetime of vision, wow, it's important, good stuff. And this is where my real interest was sparked when cross-linking first came out. Let's fast forward to September of 2017 when I got my right eye cross-linked. And why did I do it? So I was concerned that my right eye might be progressing. A year before, I'd heard a talk by Theo Seiler, who's known as one of the great fathers of the whole cross-linking procedure. And he gave a presentation documenting multiple patients in their 60s and 70s that showed sudden progression of keratoconus that had been stable for years. So I started watching my eyes a little bit more closely because I thought, well, you know, I haven't had progression for 20 years, almost 30 years. I'm 56 right now. Surely I don't have to worry about it progressing. But after reading his papers and watching his presentation, changed my thought process a little bit. And I started monitoring myself more closely. And I had my partner, who's a cornea specialist, look at my right eye, and he said, you know what? There's some stria called Vogt stria present. We look back to my prior exam from a couple years before. That was not noted in the chart. So I was even more concerned that the keratoconus was progressing. Another issue I had was I needed to work. We had gone through a big expansion. I didn't need to take off weeks or months from surgery. The budgets were pretty tight. I needed to be there doing surgery. I'm a high volume surgeon. When I'm not in surgery, the bottom line to the practice hurts. So I consulted with a bunch of my buddies who do cross-linking, and we kind of cooked up a cookbook recipe where we used the excimer laser to remove a little bit of the epithelium, 20 to 30 microns of the epithelium of the cornea, did the full 30-minute soak with riboflavin, and then did the standard light treatment with it. But this was kind of a modified Epione treatment. And the reason I did it this way is I knew I wanted to prevent a haze reaction because I didn't have time to recover from haze. I've seen some patients, it took a month or so after an Epi Off cross-linking to really start getting good quality vision because of a natural haze that occurs as the cross-linking process occurs in the deep stroma. It pretty much always goes away, but can deteriorate the vision quite a bit for a period of 1 to 3 months. I knew I didn't have time for that. I knew my keratoconus was still fairly mild. I was willing to take the risk that I might have to come back and do a full Epi Off procedure, but I had all that, the ability to have all that knowledge. So I did the procedure. I had finished doing LASIK one day, jumped back on the laser bed and had my partner waiting right there, and did the full 30-minute soak after removing the epithelium partially with the laser. And the reason we removed it is to let the riboflavin soak in better. One of the barriers to getting a good cross-linking with the Epione procedure is that the riboflavin can't soak in and get as deep in the cornea. The epithelium also blocks some of the UV light, and it blocks some of the oxygen coming in. This is an oxygen-dependent reaction. So once you burn up your oxygen, the reaction quits. So when you have an Epi Off, all of these processes occur a little bit better, a little bit faster. So the procedure itself was absolutely painless. The excimer laser removing the epithelium was totally painless. You could hear the laser firing loud. You felt absolutely zero on your eye. I felt like you would feel an impact each time the laser went pop, 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 pop. It was absolutely sensationless while the laser was firing. The riboflavin itself, you have numbing drops in the eye. There's no burning when the riboflavin's put in. The lid holder, the lid speculum, was not uncomfortable. It started getting a little uncomfortable at about 20 minutes in, and we just added some more numbing drops. That was quite easy to do. Comfort came back immediately. The ultraviolet light treatment, when you're looking up at the ultraviolet light, it's going to look blue. When you're looking at it being performed live, when all it's hitting the cornea and the riboflavin, it has a fluorescent green color. But when you're actually looking up into the light as a patient, it has a bluish hue to it. And the light was bright. It was a little uncomfortable maybe, but nothing that you should be scared of or anxious about. It's pretty boring procedure, just lying there staring at a blue light. It's one of the simplest procedures we do. It's one of the most boring procedures I do as a surgeon. As a patient, it's boring as can be, just staring at the light. It's very simplistic. There's not a lot of total art to it once the light is turned on. Once the light goes off at the appropriate time, put some antibiotic drops on the eye, some steroid drops, non-steroidal drops like Prolensa that help with discomfort. Put a bandage contact lens on, you're good to go. I drove myself home. I didn't take any Valium or take any narcotics, anything to have the procedure home. Got in the car and drove myself home that afternoon, and didn't really have any troubles. Obviously, using mainly my left eye, which is my good eye. I didn't have much vision out of the right eye. It was blurry without my prescription contact lens in, but we're all good. Got home safely, was quite comfortable till about 9 o'clock that night. And then I started having a lot of what's called photophobia, light sensitivity. The eye just being really uncomfortable. Felt really irritated by about 11 o'clock that night. It was very difficult to sleep that night. I probably slept a couple, maybe 3 hours out of the night. Had to get up the next morning, drive myself into work to do the post-ops. Had to wear my sunglasses. Had some real nice dark Costa fishing sunglasses that I wore all day long at work. I wasn't doing surgery. I was just doing post-op and preoperative exams, and that went great. I was supposed to fly out on a business trip on Thursday, and a hurricane came through Florida, and that business trip got canceled. So my wife and I decided, well, let's head up to Kentucky to a bed and breakfast together. We have a couple of days off. The kids were already lined up with grandparents, so we went on a trip. It was a little uncomfortable, but not unbearable, even being out of town. Had a good insight being a surgeon as to what was going on with the eye. Of course, I wasn't able to wear my prescription contacts, so vision was very blurry, but functioned quite well with one eye. I wouldn't drive at night, but I would help my wife with the interstate driving during the daytime without any difficulty at all, just using my left eye there. So everything went great, quick recovery. About a week later, I was back in surgery again. So I obtained the goals of what I really wanted, was trying to get crosslink. Interesting thing with the Epione techniques, though, you can't measure how deep the crosslinking went into the eye. With the Epi Off technique, you can use a corneal OCT, ocular coherence tomography, and you can actually measure how deep the haze reaction went. In Epione, you really don't get that haze reaction. So the question is, how much cross-linking did I really get? You really can't quantitate it that much. So got back to work, and we're now 4 years down the road. There's no sign of my right eye progressing at this juncture. I've not had my left eye done. I'm not anticipating having my left eye done because it is so very stable. The visual quality is a great high quality 20/20. It hasn't changed any. My prescription hasn't changed in 30 years in that eye. So I'm going to risk it. I'm going to sit on it and hope I'm not that person that changes in the 70s. But I'm also astute enough to know that the moment I see any changes occurring, I'm going to get in and sit down and have a corneal tomography done and make sure that my numbers aren't progressing. In fact, for the average patient, if you have a diagnosis of keratoconus, a lot of specialists are saying you actually ought to be monitored every 3 months. I think every 6 months is a very good way to go with it if you're stable. But if you're unstable at all, the first thing you ought to do is go get cross-linked. It's just so much better than having to deal with a transplant and a lifelong issues that come about with transplants, the risk of rejections. How long is the transplant going to last? Is, you know, when you're looking at a 20-year-old, you do the math, they could end up having 3 transplants in their life. I don't like those odds. Not when you could sit there and say, we're going to treat you and intervene early with cross-linking, stabilize this keratoconus, and get you where you can be fixed with either a scleral lens, a gas permeable lens, possibly glasses, add some laser vision correction in the future. There's all sorts of options. Intrastromal corneal rings I'm not wild about, but they do work in the right patient. So there's a lot of options out there right now. So it's a procedure. If you have keratoconus, I would not hesitate to have it done, but just realize it's going to be a little uncomfortable for 2 to 3 days. Then discomforts, it's not going to be good. I just tell my patients, you're not going to feel real comfortable for 48 hours minimum. That was my personal experience with it, but it's not something that just incapacitates you either. So it's well worth 48 to 72 hours of sacrifice to get stability of vision over time. Jason, what do we have question-wise, thought-wise of where we would want to proceed now?
Yeah, sure. Thanks. That was really interesting and kind of, you know, fascinating kind of history on your experience. And maybe a place to start was one thing that you said early on when you were talking, the analogy, I like what you said about how you might be at a football game and given the prevalence that there's most likely others out there in that group that also have keratoconus. And I think that's an important thing for people to hear because, you know, with contact lenses being the treatment, a common treatment, a lot of times people look at an individual with keratoconus, may not even know they have anything going on. And I feel like it can be somewhat isolating. Feeling like they may be the only one who's suffering from that. They may not know someone else who has keratoconus. So I really, personally, I appreciate that, that anecdote.
You know, I actually have a patient who goes to church with me. He has keratoconus. He's been stable for years wearing gas perm contacts. I told him, I said, you may really want to get cross-linked just to make sure you don't progress. And he says, hey, if it progresses, I'm coming in immediately, but until it does, I'm quite comfortable just wearing my gas perm contacts and sticking with it. So it's like you said, you would never know it talking to him in the foyer of the church that he had keratoconus unless he had shared it with you or he'd come in as a patient.
Right. And maybe a little bit more on your experience. If you kind of think back to the kind of when you were first diagnosed and perhaps even the day you were diagnosed, because you had an insight, you know, having been in the studying to be a medical professional, was that day, that diagnosis day, if you will, is that memorable to you? Is that something that stands out?
Oh yeah, absolutely. Because we knew that there wasn't a treatment for it, right? The only treatment was a cornea transplant at that time. And I was contemplating, in the fourth year of medical school is where you decide, are you going to, what you're going to specialize in. You go into something called the match. And I was trying to decide, well, I planned on being an ophthalmologist. Is my vision going to be good enough to have this career, right? I knew I'd be good enough to do internal medicine or maybe anesthesia or some other procedures, but vision is super critical to surgeons, especially with microsurgery that we perform. We have to have good vision, and I was concerned. Produced a lot of anxiety for me. When am I making the right decision as a career choice here, right? Because this does progress what's going to happen, and even if I have a transplant, I'm probably going to get good vision because most people with keratoconus have a good outcome with transplants. But, you know, you always have seen the patient that had rejection of their transplant, or they have irregular astigmatism that's maybe even worse than what they had with keratoconus, or they get a cataract, or they get glaucoma from the steroid drops for to prevent rejection. So there's just a whole host of these things that are going through your mind, wondering, you know, how's this going to end up? Is it gonna, am I going to get a full career? You know, I'm 56 now. I think the answer is I'm probably going to get a full career in ophthalmology with this diagnosis. And I've had a great career already and enjoy my work. And I just feel blessed that I could do this, right? And then I can hopefully coach other people with this and help them with their keratoconus.
Right. Yeah, I think, you know, that's an interesting point you make about kind of being at a crossroad almost, if you will, at that point, having to make the decision. I think, and for individuals in a career like yours, it's, you know, it's not as easy as just, okay, I'm a medical doctor, I'll choose this other specialty. I mean, it would require a lot of, I mean, almost going back to residency, right? To move into it.
Yeah, I was lucky. I was applying for residency positions when we really got the full diagnosis of it and started progressing on me. So I hadn't made the total leap, but that factor was always out there. You know, the risk was, if this progresses, I'm probably not going to be able to do surgery. I could be a medical ophthalmologist, but I may not be able to be a surgical ophthalmologist like I dreamed of, right? Because I came from a family of ophthalmologists, and I'd planned on going into this. I went to medical school to become an ophthalmologist, not to become a heart surgeon or an internal medicine or anesthesiologist. So it was anxiety producing, thinking I might not be able to go into what I'd really had a passion for.
Sure. So this might be a little bit philosophical, but given you were kind of headed in this direction, do you feel as though maybe, you know, that you were kind of, you having it was kind of both a blessing and a challenge at the same time? Do you feel like it has maybe changed the way maybe you approach your patients?
Absolutely. And it gives me a different level of continuity of care with my patients to sit there and say, I'm going to do the exact same procedure on you that I had done on this eye, right? You're going to feel this. This is going to be your sensation. It's going to hurt for this number of hours, and then it's going to start feeling better, and then the vision's going to start coming back again. It's a different perspective versus, hey, I've never had this done. You know, this is what the literature shows, right? So it's given me a better ability to talk with my patients about how this goes. And, you know, I kind of think that goes back to all things work together for good, right? That old Bible verse. And maybe this was my destiny, who knows, but I'm happy with where I am, and life's been good to me, and I just hope I can continue to help other people for years to come.
That's really great. You also at the beginning talked a little bit about how the procedure is not currently a reimbursable procedure, and that seemed to be something that maybe perplexes you a little bit. If you would that be? I mean,
yeah, it's a hassle, and you know there may be some folks from Avedro listening in. Avedro is they make a great product. Okay, there's nothing wrong with their product. It's the reimbursement, and they put all the expense of the reimbursement on the physician. So just elementary school math here is you have to buy the light, and then that's $50,000, I think. And then the riboflavin, the purchase price it's around $2,500 to turn the light on and use the riboflavin. So that's called a click fee. Well, the problem is I have to pay for all this before I perform the surgery, right? And we get a pre-authorization from the insurance company, and they say, yeah, sure, we cover this. Okay, we got an authorization letter even. We perform the procedure. The procedure takes an hour of my time. During that time, I could have performed 6 cataract surgeries or 8 eyes of LASIK surgery. So this is kind of a procedure that's not a big money maker for the practice. It's something you do out of a calling and a love. It's not something that's going to put a lot of revenue in your practice. It takes a lot longer than other procedures. The reimbursement's poor for it. And then a lot of post-operative care chair time compared to a cataract surgery. And then the insurance company doesn't ever want to pay you. And this is a problem across the nation. The company will tell you, oh, so-and-so will pay you. I'm like, well, okay, how about I just go use your program and you go get the payment and you pay me for it, right? Oh, no, they won't do that, right? They won't be responsible if I don't get paid. So that's my problem with the whole system now is the insurance companies say they will pay it, but when you go back to them, a lot of the time they don't pay it. They make you resubmit claims multiple times. Then they still don't pay it. It's a big hassle, the reimbursement for it. So I can't advertise this, but I have gone to just a total non-FDA approved system with specialized consent forms for it using a European cross-linking system. And the reason is I feel like I'm doing this more out of labor of love for my patients. It's cash pay. You may say, oh, well, that's a lot of money. It's really not that much money when you look at the expense we go to, all the pre-op exams, all the post-op exams, the length of time it takes to perform the procedure. It's more of a labor of love for me, and one of those things I feel like is a calling for me. But we do have to cover our costs. I'm very upfront about that. We have to be able to cover our costs, and the Avedro system is just not doing that for doctors. And I know that other cornea specialists, I'm in Nashville, Tennessee. I'm friends with a lot of the other cornea specialists. They're having the same troubles I am. They told me that we can't get reimbursed from this insurance and that insurance. We've had to quit doing it on these patients. It's kind of a sad story when you have a procedure that really works and works well and is the standard of care in the rest of the developed and undeveloped world, but yet we can't get reimbursed for performing it in a cost-effective way here in the United States.
Yeah, well, it sounds like there's some significant challenges there. When you do actually perform the procedure, have you had instances where individuals have actually undergone the procedure on the same eye more than once, or is it like is it typically a one-time procedure?
It's typically a one-time. Now, there's multiple documented cases in the medical literature of cases where you've had to come back and they've shown later progression. I've not had one of those cases yet. We've been 100% successful in arresting the progression of the keratoconus with cross-linking, but it's eventually going to happen to us as well. The numbers catch up with you. I tell everybody, if you do a lot of surgery like I do, you've seen every complication to occur because it's just a mathematical probability. No matter how good you are as a surgeon, if you do lots of surgeries, and I do over 100 a week on an average week, you're going to see some complications occur.
Yeah. Okay. I'm thinking about, it sounded like when you were speaking, the trigger in your case was you noticed progression. So is that kind of how you counsel patients to think about the procedure, is if you're noticing progression? Do you ever counsel individuals who maybe aren't progressing that this might be a good choice for them?
Absolutely, absolutely. If I see a young person who's 17, 18, 19 with steep keratoconus, there's no doubt they're progressing. They may just not know they're progressing, right? I'm going to tell that young person and their parents, it's my advice that you go ahead and do this. And let me tell you my story, right? I wish I had had someone and a procedure that could have just stopped this in its process, so that maybe I could have come back and had an implantable contact lens, or I could have had a laser PRK adjustment of my eye in the future. That wasn't a possibility with me because we didn't have that technology. So I very highly, strongly recommend, if you're 18 and you have keratoconus, it means you're probably going to progress. You know, if you're a little later onset in your 20s, maybe you don't, who knows? But it's a lot about how steep your cornea is. If you're seeing someone with a very steep cornea, getting up there in the 54, 55 range, when you first see them, they really need to be cross-linked. If someone has a subclinical cone and their steepest spots on their keratometry is 48, 49, maybe you say you wait on it, you know, especially if they're 20/20 vision still, and coach them on no eye rubbing. Just look at it on a case-by-case basis. But with steeper cones, I just tell people, you need to have this done. You need to do it as a gift to yourself. The reward way outweighs the risk with the procedure.
You know, when you're talking to patients about the procedure, is there any like discussion about, and you kind of touched on it briefly, about an improvement in refractive error, or you talked about reducing the maybe it was corneal astigmatism by about a diopter and a half, but
that's correct.
Do you talk at all? I mean, is there any thought about like this may reduce refractive error, or do you simply kind of counsel it, this is going to arrest the progression, and we will think about contact lenses and the correction of the refractive error as a separate topic?
I go with the latter, Jason. If you look at the medical literature, the real reason to do cross-linking is to stabilize the cone and prevent progression, right? That's your primary endpoint right there. Have I seen patients that had significant flattening with a 30-minute cross-linking and, you know, 3 diopters of flattening, 4 diopters of flattening? Sure, I've seen it. But if you look at the medical literature, the average is about 1.5 diopters. So I tell people, don't expect to not be in glasses or contacts afterwards. Now, if people get a really good effect, if the eye looks good and stable a year out, I wouldn't hesitate to come back and do a laser PRK procedure. You may not want to treat the full astigmatism or the full amount of nearsightedness, but you can do what I call debulking the astigmatism. You can dramatically reduce it by anywhere from 30% to 70%, depending on how high the astigmatism is, and make it easier to be functional with glasses or contact lenses.
Is there any like literature that describes the effect of the procedure on irregular astigmatism or the higher order aberrations that accompany the disease?
You know, I'm not sure I've seen one that goes over higher order aberrations, but everybody who has keratoconus has gobs of higher order aberrations. I'm just here to tell you. You can look at a pentacam in a little box called the RMS higher order, and it's going to be up there. It's going to be above 1 on most all of us that have keratoconus. So yes, you can decrease it, but that's not something I would have cross-linking for, saying, oh, I'm expecting to decrease my higher order aberrations necessarily.
Mm-hmm.
That might be a little bit of an unrealistic expectation there.
So individuals, if maybe the majority of individuals that you're working with are maybe wearing contact lenses before the procedure. Would that be accurate?
It's interesting. A large percentage of patients I see are not actually in gas perm contacts and are newly diagnosed keratoconus patients that are coming in to see me. And it's amazing how progressed some of them are when they're coming in with a referral. Unfortunately, some of them have very advanced cones before they're sent in to see us. And it seems like there's some sort of tendency for patients to deal with it and just say, wow, I'm really seeing bad out of this right eye or left eye, but you know what? I don't want to go to the doctor. And they don't go to the doctor, or I don't know if they see someone who doesn't know what they're looking at or doesn't know how to counsel them. But a large percentage, unfortunately, of my patients aren't coming in with mild early keratoconus. They're coming in with highly advanced keratoconus where the treatment and the prognosis is not as good. We might cross-link them, and a year later, they may still have to have a transplant. We can't guarantee them we're going to even prevent the transplant. So it's kind of unfortunate, I think, that somehow in the community, we're not diagnosing this quick enough and fast enough and being definitive enough with the referral process.
Mm-hmm. Yeah, that's an interesting point. I think, even sometimes individuals, if these changes occur relatively slowly, sometimes they may not even know what they don't know, in a sense, right? Like they may have progressed and not even remember the kind of vision they had when they were 20 or 18, or you know what I mean?
That's right. And I don't mean to slam any medical professional, but a lot of the contact lenses and glasses are done by people in the mall, right? Or just at a large commercial provider. They don't even have corneal mapping at most of these sites. They don't have topography or tomography. They're not doing that on a routine basis to detect it. A lot of the doctors in private practice have them, but the general providers that you might go to at one of the commercial places that are in a strip mall or mall, they're not bad doctors. They just don't have the equipment. It's not what they're set up to do. It's just they're set up to do glasses and contacts. That's their business model. That's what they do. They're not set up to do medical eye care. So you come in with some more astigmatism. It's the first time they've ever seen you. Sure, here, we're just going to change your glasses prescription and come back and see us in a year, right? You come back in a year and, oh my goodness, it's gone down the tubes. You've progressed. You've got 7 diopters of astigmatism instead of 2 now. And wow, maybe something's wrong. We need to get you a referral, right? Where if they'd come in and had corneal mapping done, you would diagnose it much, much earlier. So if there's any sign that your vision's really fluctuating, you need to have somebody who has corneal tomography or topography to map that cornea, because it's easy to find it and spot it if it's there.
Yeah, and another thing that maybe you were kind of alluding to there, would you think it's important, the continuity of care for an individual to kind of be followed within a practice over time? Certainly, people change practices and things like this, but maybe because it is a progressive disease, really important to kind of find someone that you relate to, a good partnership with your medical professional between the patient, and kind of have that continuity over time.
Absolutely. You need to stay within the same practice, really. It's too difficult to transfer the medical records. It often doesn't get done, even though it should, right? But it's just the fact of life. Getting those charts from another doctor and getting them put into your EMR where they're readily accessible sometimes that stuff just doesn't occur, where if you stay with one practice and they're monitoring you on one brand of machine, you're not switching from a Natick OPD to an ISIS to a Galilei to an Oculus Pentacam each visit. You're not getting 4 different opinions in 4 years. There's a lot to be said for continuity of care wherever you go. Now, if you have normal, healthy eyes and low astigmatism and you're doing great, there's nothing at all wrong with seeing your doctor in the mall. I want to be very clear. I'm not slamming these providers. They do a great job and they're diligent in the work they do. It's just we have a very mobile population. People don't stick with the same doctor. They go to Walmart one time and then they go to VisionWorks or LensCrafters the next time, and then they go to a private doctor the next time, and then they may see an ophthalmologist the 4th time, right? So it's just a function of our mobility in our society, and people move from one city to another city. It's just, we live in a very, very mobile society now where continuity of care is more of a challenge. We're not just sitting in, working in our same town that we grew up in and expect to retire there 40, 50 years later.
Sure, yeah. Maybe just, this is really great. A couple more here from the audience. You mentioned kind of being out of your lens for a bit. Sounded to me like you really made sure it didn't have a big impact on kind of what you were doing immediately, but how long until you were back in your lens?
It was about 6 days, I think. Yeah, 6 days before I could put my gas perm contact back on my eye.
And with your experience, did it end up needing to change that lens?
I did have to change it. It was a small change, though. If I had had an Epi Off crosslinking, I would have expected a lot more change with it potentially.
Mm-hmm. Okay, I see. So the fact that you had the Epione maybe reduced the change that you saw.
And that was part of the calculated risk, right? Mm-hmm. Maybe less effect of the crosslinking, but quicker recovery and more stability of vision immediately after surgery.
Sure. And what, as a corneal specialist, what is, you have kind of these, kind of when one treatment evolves, maybe focus on the other is changed. Has this kind of changed your focus on transplant or the field's focus on transplant? Or is there any kind of evolution in the area of transplant that may be related or anything like this?
Well, it hasn't really changed my focus that much on transplants. You can use femtosecond lasers for transplants now, where you actually cut the cornea and use a laser to get a stepped incision with that. You may get a little less astigmatism, a little bit faster healing with a stepped incision than a regular blade transplant incision. My focus of my practice has really been, though, trying to prevent transplants rather than doing transplants.
Right, yeah, sure. Okay. Yeah, one maybe just kind of technical question might be, did you, if you think about like it sounded like to me like the quality in your left eye, you said was like a little bit sharper than your right eye.
Oh yeah, I have super good vision, thankfully, in my left eye. Really acute vision.
And did you notice any?
I have a fairly steep cone. It's really kind of amazing. But because of that cone, I have a multifocal cornea. I'm 50 years old, and in my left eye, I can still see 20/20 at distance and 20/20 at near. It's kind of weird, kind of bizarre. I don't think I want to touch this eye. I don't want to fix it. I can still read without glasses, My right eye, I see pretty good at distance. I would need readers to see well up close. So I'm kind of functioning with a modified monovision, you might say, right now, where one eye's for distance, one eye for near, but it's really that one eye has both.
Yeah, certainly the the refractive problem that comes for us all in the end is presbyopia. So sure,
That's
yeah.
right.
I'm noticing that for myself. It's like, wait a second, I used to be able to do this right here. So anyway, maybe, have you, maybe from your experience or from the literature, from what you're hearing from your colleagues, where do you think Epi On versus Epi Off is headed? Do you think that these will always be like two offerings, or do you think maybe one will become dominant, or what is your impression there?
I still think Epi Off is going to be the dominant. It's just math, right? How much oxygen, how deep do you get the riboflavin in the light, right? And
Sure.
I don't think we're going to get beyond that. There's some great doctors doing great research on Epione. There's a lot of ambiguity in people judgment of those studies and how they're going. Some people claim they're going really, really well, and their studies show some pretty good outcomes. Other people in Europe and Asia are saying, nah, no way is this working as well. So I think the jury's still out. I think Epione's a great procedure to try if you're early in your keratoconus, you're wanting to stabilize it, you're wanting low risk, you understand, you know what, if it doesn't work, I'm going to have to come back and do an Epi Off procedure. You're not going to get mad about it. You're not going to say, well, I paid X amount of dollars and this failed. You just have to understand what you're getting with it. And it may work. It may work very well for you. It may not be enough. It's my opinion, no matter what you do with Epione, you're going to have a higher recurrence rate and a higher retreatment rate.
Yeah. Okay. Maybe two last quick ones here. We did have a couple of questions about whether individuals with other conditions, if there's any information on whether or not some other conditions, in one case, maybe an individual undergoing chemotherapy, if that might kind of instigate keratoconus to progress more. I know that's kind of a very focused question in that, but I'm curious if there's a place that individuals can go to learn more about questions like that, because it seems like maybe perhaps the numbers of individuals with both of those might be low, but do you know, are there places that one might go for that kind of information?
Yeah, that's going to be a tough one. I'm not aware of chemotherapy affecting it. There's so many medical journals out there with case reports, though. Yeah. Whether it's Journal of Cataract and Refractive Surgery, cornea, you have so much good research going on in Europe and China now. There's a tremendous amount of good research in India. Produces a lot of great ophthalmology papers right now. I would just Google it and see if there's any associations out there. I'm not aware of any off the top of my head, but new research into unusual conditions is not really the focus of my practice.
Right. Well,
trials, but we're not doing biologic research per se.
Yeah, and those, I mean, again, it can be challenging, from a scientific perspective to make definitive conclusions sometimes when numbers may be relatively small and it's difficult to control a lot of variables.
And it goes back to the continuity of care you just brought up, Jason, right? Mm-hmm. Did I do an exam on you 2 years ago before you got a diagnosis and were on chemo, right? Where I could compare your corneal maps prior to chemo to post chemo, right? Yeah. If I don't have any maps to compare to, I can say, well, I don't know. Could it be the chemo? It could be, but it's not definitive.
Right. Yes, I understand that. Yeah. Well, there's a lot
of things that occur in association. They just happen to occur at coincidences at the same time, right? I've had a patient before that had a retinal artery occlusion after cataract surgery, a couple of days after cataract surgery. Well, the patient immediately thought the cataract surgery caused the retinal artery occlusion. Well, it had to do with carotid artery disease. You know, she had a blocked up carotid artery, we found out later, caused that to occur. But they occur at the same time. So you say, oh, well, obviously this caused it, when it had nothing whatsoever to do with it.
Right. Well, this has been really, you know, informative. It's been interesting. I appreciate you sharing your experience. You know, it's kind of a, like you mentioned in the beginning, you perhaps have a truly unique experience here. And I think everyone, you know, here on the call tonight, and those that will watch it in the future will benefit from this insight. So, you know, maybe as a last question, do you have anything to kind of, if you were kind of parting words for the individuals who are listening with your experience and then cross-linking, what would you kind of leave the group with tonight?
Yeah, if you have not been cross-linked and you have keratoconus, find a reputable doctor with a lot of experience and cornea specialist. Go see them, talk to them about it, and trust them. Trust what they're telling you about the procedure. Guys that I found in cross-linking are doing it not because they're mills and that they're wanting financial remuneration for the procedure. Most of them are doing it because they really like taking care of patients. And you've got to take that leap of faith and find somebody you trust, that you feel like they're really giving you a straight answer and that they have the experience and knowledge to help you through the decision-making process as to whether this is the right time for you or not. And there's plenty of great physicians out there in the United States. They're experienced with cross-linking. It's not something that's going to be in every even mid-sized city. You may have to go to some of the larger cities to get access to these professionals, but they're all across the country, and trust them and move forward with it. Don't let yourself be at risk of having a transplant. Okay.
Well, with that, Dr. Loden, thank you very much for just a really great presentation this evening, really insightful. And thank you to all of our attendees this evening for joining us. Please be sure to join for the September webinar, which will be presented by Dr. Major Mosherfer on the topic of corneal transplant. Also in September, the webinar will have a new host, Dr. Gloria Chu. And I, for one, am very excited to see the direction that she takes this webinar series. Until then, we hope you remain safe and healthy, and good night.
Good night, Jason. Thank you all.